Hi, I'm Kristen Hodgden, IVF mom, proud women's health advocate, and co-founder of Rescripted.
And I'm Dr. Jenna Khan, a board-certified OBGYN, fertility specialist, and mom of two.
And from first period to last period, we're diving into the women's health topics that matter most, from periods and fertility to pregnancy and menopause.
Through expert interviews and candid conversations, we're empowering women to take charge of their health by expanding the discussion beyond what's typically covered in the doctor's office.
It's time to stop guessing when it comes to our health. Now let's dive in for the real science-backed info you need to be the expert in you. Hi, everyone. Welcome back to From First Period to Last Period. For those of you who are new here, I'm Kristen, co-founder of Rescripted. Jenna. Hi, Jenna.
Hi, I'm Dr. Jenna Khan, board-certified OBGYN and fertility specialist and mom of two. Really excited to be back here with you, Kristen.
Yay. It's been a few weeks because you were studying for the oral REI boards. So how did that go?
Oh my gosh, it was a whirlwind. It was like, it went by so quickly. It was 3 hours of like constant rapid fire questioning,
Wow.
like in a cold sweat the whole time. And then when I was done, I was like, so excited. But then, having 3 hours to sit on an airplane after the fact, was like, oh my God, why did I say that?
Oh my gosh, I'm sure you did amazing. You do this in and out every day
Exactly.
for your job. So I'm sure you killed it. But yeah, what else is new? It's been a couple weeks.
So this is like the first time that I'm sharing this, but I'm like so excited about it. I am freezing embryos in the next couple weeks. I'm like so pumped about it.
That's amazing. You're like, got the boards done.
Yeah. Yes. And we actually, like every year for National Infertility Awareness Week, we do a Meet the Doctor session where, patients that we have helped conceive, they have the opportunity to like bring their children in to like a photo shoot to like meet the doctor that helped create them. And this was my first year at the practice to do that. And like, my ovaries were like, oh my God, you've got a third baby in you. And I have like, there's no capacity in my current life for a third baby right now. And so, but like in a couple years, maybe 3 years, like for sure, I can see that now. I'm finally like out of the dust of like my crazy board studying life and my infant. And I can see the time period where a third kid would be amazing. And yeah. And, I had such a hard time conceiving my second, and I have like a lot of PTSD surrounding that. And I was like, I was essentially like, needing to start IVF, but moving cities, and was like, okay, as soon as I get myself settled, like I'm going to just start the IVF process. And for my second, I did like 10 monitored letrozole cycles. And it's definitely more than I would even recommend a patient of mine. But just given where I was in my life and moving, I did what I could. And my thought was like, I'll just do IVF when I get settled. And then I somehow got pregnant. But, thinking about what's it going to be like for baby number 3 when I'm like probably 5 years older than when I went through that process.
You know better than anyone. And to that point, I actually always talk about this, but my IUI and timed intercourse cycles with Clomid and letrozole were more traumatizing to me on my first journey than IVF. Like at the end of like multiple failed IUIs and timed intercourse cycles, I was like begging to do IVF at that point.
Yeah, because you're still in it. You're going to all these visits and you feel like you're doing something, but then when you're not seeing results, it's like, what is happening here? Like, what is failing? But that just sort of speaks to just the inefficiencies of human reproduction a little bit. And, IVF does give you a little bit more control, which, I'm seeking that, as well as, fertility preservation, if I'm in my, late 30s, early 40s trying to conceive, I will find, comfort in having some embryos.
Oh, totally.
You
Yeah,
see some.
absolutely. I know. That's such a like privilege to be able to, and you know better than anyone else, to like age
For sure, for
infertility.
sure. I feel so fortunate to have insurance coverage for this, and
Well, that's amazing.
yeah, um, and in my practice, majority of patients have insurance coverage, and so I feel like, yeah, I yes, I have all the knowledge
Mhm.
to want to inform this decision, but also yes, I feel very fortunate to have really good coverage for it as well.
That's awesome. And you were telling me right before we started recording that you started birth control, which feels such like
Oh my gosh,
the
yes, it's
antithesis of what you're supposed to be doing when you're trying to conceive.
yes. So I'm like horrible at taking pills in general. I always forget, which is why I have an IUD. But one night I was like, oh, I forgot to take my birth control pills, and my husband was like, birth control pills? Like, why are you taking birth control pills? And I was like, oh, here we go. Like, this is the start of my of the window into how patients think. And when I talk about starting birth control pills as sort of a priming for IVF, like, why do I need to start that? And
Yeah.
we need to rename them. Instead of like birth control pills, call them like estrogen and progesterone pills, or like
Yeah, call it what it
cyclopentine.
is in IVF for
Yeah,
sure. Well, I'm sure you're already a very empathetic doctor, but I think this will probably make you even more like attuned to what your patients are going through for sure.
for sure. Yeah, I'm excited.
Well, good luck with that. I've been through
Thanks.
it many times, and sometimes starting is like the hardest part, like just waiting to start, and then once you're in it, you're like,
Yeah.
okay.
Yeah. I have to like go pick up my box of meds, and um yeah, I've been wanting to do this for a while, and I keep like having excuses like, oh, like I'll do it in this month. But I think one, getting the motivation to start, and then two, like the first I remember from like my trigger shots, like the anticipation of like, oh, what's this injection going to be like?
Yeah, exactly.
So,
Well, it's all good stuff.
yeah, I'm excited.
Um, so for Her Story Unfiltered today, we have, speaking of pregnancy, a story all about hyperemesis, which I was actually talking to a fellow local mom here yesterday, and she said that she threw up for 10 months with all four of her pregnancies. And I was like, and you did it 4 times. So let's listen to Shea's story. Her Story Unfiltered, raw, real, and rescripting women's health, one powerful story at a time.
My name is Shea, and I live in Los Angeles, California. After struggling to conceive, I finally got pregnant and was so excited to enjoy expecting. Very quickly, my giddy excitement turned when I started feeling nauseous. I took it as a good sign at first, a sign of a healthy pregnancy. I bought ginger ale, ice pops, seasickness wristbands, and lollipops to calm pregnant tummies. If there was something on the market for morning sickness, I was the target audience, and I was all in. Sadly, I quickly went from getting sick once a day to multiple times a day. If I threw up 8 times a day, it was a good day. I stopped eating and drinking and had trouble remembering that I actually liked food once. I was diagnosed with Hyperemesis Gravidarum. I lost so much weight, but my doctor didn't seem concerned until I was 96 pounds at close to 5 months along. He gave me a medication to stop the vomiting for a few days. It was a Friday, and he said I had to maintain the same weight or gain weight by Monday, or else he would have to hospitalize me for a feeding tube. The medication made me drowsy, so all I needed to do was eat, drink, and sleep. It was working until I started to feel restless. I couldn't be still and felt this uneasiness from my toes up to my head, and when it got to my jaw, it just locked. My jaw stayed locked for 16 hours. My doctor said it would pass and that the baby would be okay. By the end of the day, my husband was the one throwing up from all the stress. Miraculously, my baby was safe through it all, and a few months later, I gave birth to a healthy baby girl.
Wow. First of all, Shea, kudos to you. I mean, not like you had a choice, like so many of us women that what we go through, like we often don't have a choice, but I really commend you for getting through that whole experience.
Yeah, that sounds so rough. And I have like flashbacks to when I used to work on labor and delivery, and
Mm-hmm.
having these women just like hang in the hospital for days. We doing like what we call them, like PO challenges of like them taking some ginger ale and some crackers, and like just making sure that they could eat something before they leave. And it was rough.
So what is HT? Like, is it,
So it's
well researched? Like what's
yeah.
the deal?
So it is the persistent and excessive vomiting that interferes with daily life, and it's associated with dehydration and electrolyte imbalances. Signs of dehydration in the urine. So that's called ketones in the urine, and then weight loss of more than 5% of the pre-pregnancy body weight.
Mm-hmm.
And if your signs of this would be like if you're not able to keep fluids down for 24 hours, or your urine gets super dark, or you aren't peeing at least every 8 hours, that's a sign of profound dehydration, and you should be going to the hospital for an evaluation.
Mm-hmm.
As far as like a stepwise approach to treating nausea and vomiting in pregnancy, most doctors will start treating with the over-the-counter things, like ginger chews and Unisamin B6 vitamin, which is really the brand name for that combination is called Diclegis, but you can, break it up into just Unisamin B6 vitamin.
I actually took that with my twin pregnancy. But I don't know if it was a Diclegis or just the fact that I was pregnant with twins, but it made me really sleepy. Is that common?
Well, so the Unisom is,
Okay.
will make you sleepy, but you're supposed to take that part at night. That's why I like to break it up, because you can take the Unisom part at night and it helps with next day nausea. It's really not the best for like in the moment nausea,
Yeah.
but it's a good preventative measure.
Yeah. Because this time around, I was scared to take it because I had two other kids. So I was like, I can't be sleepy.
No. And then there's also like the seasickness bands. And if that stuff doesn't work, then you can step it up to oral, prescription medications like Zofran, Reichlan, Compazine. And then there's also suppositories like Phenergan that can be helpful, especially when you can't keep anything down.
Mm-hmm.
And then I've seen it are all the way stepped up to, once someone is discharged from the hospital, going home with an IV home infusion service. They come and they give you the IV medications. And again, that's for like really severe cases to prevent the needing for prolonged hospitalization, needing for feeding tubes and all of that. That's like extremely, extremely rare.
Okay.
Fortunately, a baby is pretty resistant to this condition. In only like severe cases of malnutrition can fetal growth be affected, but usually for the like most common forms of hyperemesis, the baby does just fine, as Shea had mentioned.
I
And usually,
remember feeling like in the beginning of my twin pregnancy, like, how are they getting enough? Like, just because I obviously didn't have HT, but just not wanting, protein, like just having like grilled cheeses all day,
yeah, and
not wanting anything nutritious.
yeah, and there's like you recommended weight gain in pregnancy, but it doesn't really apply to like the first trimester. It's more like as the baby's starting to grow and like pregnancy overall. But if you don't gain any weight in the first trimester,
Yeah.
that's not a problem. The baby itself is weighing like, nothing, it's really, really small still. And, this usually will resolve around 20 weeks. But like you mentioned with a friend, and my sister-in-law was the same way, like vomited every single day of her pregnancy until the baby came out. And so there are some cases where it can linger. And then if you've had hyperemesis in the past, you are unfortunately at risk of having it again. And so sometimes pre-treating with these medications, like before you even have symptoms in the way beginning of the pregnancy, can be helpful. So like starting the Zofran or whatever medication worked for you, at 4 or 5 weeks, absolutely. That could be helpful.
Do you have any recommendations for someone who might go to their OB and they just get told like this is a normal part of pregnancy, like how to advocate for yourself kind of in that situation?
Yeah, well, so there's a fine line between like normal nausea, vomiting, and pregnancy, and then like all of a sudden it's no longer normal.
Mm-hmm.
And so I think it's important just keep the doctor informed, like if you're having nausea and vomiting and whatever they're telling you to do isn't working, like you tell them right away, this really isn't working. I've tried this for a couple of days, still not working. Or you tell them I haven't been able to keep anything down for 24 hours. Like they should really be taking that seriously
Yep.
because if your mindset is like, oh, I already told them last week, but it's been a week and you're still like not keeping anything down, like that's when it becomes a problem. You start to see the weight loss. Like you just shouldn't just assume like, oh, I already told them, they should know. It's like, no, you've got to keep them informed, especially in that beginning part of pregnancy. You're only seeing them every 4 weeks or so.
Yeah.
So, just keeping them informed, like this still isn't normal, every couple of days. So they know that this is it's an evolving situation.
Yep. No, that's good advice.
Own your health. Ask us anything. Your questions and expert answers, because you are your own best advocate.
So we got a bunch of really great questions from our community for Own Your Health. One of them is, what causes mid-cycle spotting and when should I be concerned?
This is a great question. And mid-cycle spotting can come from a lot of different things. And so I'm just going to break this down into different categories.
Mm-hmm.
The first one is one that I see all the time, ovulation bleeding. So when ovulation occurs, there is an abrupt shift in hormones. So with the ovulation, that's like the LH surge that you guys are detecting on the ovulation predictor kit. So with that comes a drop in estrogen, and then progesterone starts to rise, and then slowly the estrogen follows suit and starts to rise again. Mm-hmm. But this abrupt change can cause some instability in the lining and cause some spotting. So that's number one. Number two, bleeding from polyps or fibroids. And these are benign growths within the uterine cavity that can cause some irregular intracycle spotting or bleeding. This usually isn't as predictable, but might look like spotting or even a more significant flow. Mm-hmm. I think if this is something that's like persistent or like happens every month, it's helpful to like keep a diary of when this happens, so you can show your doctor and they can sort of help navigate this part. But then there's cervical bleeding, and cervical bleeding can be due to pelvic infections like chlamydia, gonorrhea, and cause like cervical irritation, and therefore irregular unscheduled spotting. But then there's also cervical bleeding from what's called an ectropion. An ectropion is this well estrogenized cervical tissue that's just really delicate and can bleed when it's poked. So poked with an ultrasound probe or poked with a penis can cause some bleeding. And so if you're trying to conceive and after sex you have some spotting, this might just be due to a well estrogenized cervix with an ectropion.
Okay.
Then there's anovulatory bleeding, which, this is for the patients with PCOS. I've had patients with like 40 plus day cycles and think that they're ovulating because they're having some bleeding somewhat regularly, but they're not actually ovulating. And this is really what I call overflow bleeding, because the lining just builds up and up and up over time and just gets so thick and unstable. It just outgrows its own blood supply and then just sheds in an uneven way. And for some people, this might feel like mid-cycle bleeding. Mm-hmm. And then the last cause is something called iatrogenic causes, which means caused by medical treatment. For example, hormonal contraception. If you're having mid-cycle bleeding while on birth control pills, it means that the estrogen dose in the pill is just too low and the lining of the uterus is just too thin and unstable, and is subject to random bleeding. And you can fix this by changing the type of birth control pill to one with slightly more estrogen, because it's that estrogen that will thicken the lining a little bit and make it a little more stable.
Got it. Funny, I didn't know about ovulation bleeding. I knew about ovulation pain. So my kid's tutor, actually, she just found out she's pregnant, and we were talking about Rescripted and trying to conceive and stuff. And she was like, I was on birth control for 10 years and I didn't realize when I came off of it that she said I had like period like cramps for literally like 24 hours when I was ovulating. And I was like, oh, lucky you, like, you know, when you're ovulating, but I didn't realize that bleeding could also come with it.
Mm-hmm. It's less common, but I've certainly seen it.
And then also implantation bleeding. But that's if you're actually pregnant.
Right. And that would be like a little bit later, like, you know,
a little bit
probably
later,
like a little more than a week after ovulation.
Yep. Yeah. I've had implantation bleeding I've been pregnant 4 times and 2 of them were miscarriages, but I had implantation bleeding every time. But I don't know if that's like just a thing with me, but
was it before you had a positive pregnancy test?
Yeah, it was like a couple days before. Yeah. But still, like, going through IVF, you're like, this could be anything.
Right.
I'm never like, this is definitely a good sign.
Right. That is so true.
So this question I actually threw in here because I'm so fascinated by how autoimmune issues can impact fertility. And just wanted to like see if you could talk a little bit about like conditions like Hashimoto's or like lupus. My best friend has lupus. Like, you know, in theory, your like body is attacking its own tissue. So like, how does that, like, is there more research on the horizon about this? What do you want patients to know?
So autoimmune diseases are just a really broad category in exactly what you just said. Like the body is attacking itself, but the manifestation is really dependent on what the body is attacking. And so like in lupus, it can impact connective tissues, but also the kidneys, and can have like a multitude of different manifestations in that person. But like Hashimoto's is an autoimmune condition that impacts the thyroid. And so the way that it affects fertility is really just like how the thyroid hormone is important for fertility and pregnancy. And so just using Hashimoto's as an example, thyroid hormone is really important for the communication between the brain and the ovary. And when we have an underactive thyroid and not producing enough thyroid hormone, like in Hashimoto's, you can have, like with the issues with the brain and ovary communication, you can have issues with ovulation. And so ovulation dysfunction is really like the main way that hypothyroidism from Hashimoto's causes fertility issues. But hypothyroidism is also associated with recurrent pregnancy loss. And thyroid hormone in general is really important for early fetal brain development. And so in lack of sufficient thyroid replacement in these patients can result in neurological and developmental issues for those children. So that's just like one like tidbit of like how autoimmune conditions can impact fertility, but just depending on the autoimmune condition, it's like not every autoimmune condition is created equal in the way that it impacts fertility.
Totally.
Specifically with thyroid issues though, like it is a very treatable condition. Like it's a very easily treatable condition, and the medication is really well tolerated. And once the condition is treated, like ovulation is typically restored and the impact on pregnancy loss goes away. So this is one of the easier ones to treat.
Yeah, absolutely. I guess the piece that like I'm wondering if more research will come out about is like TSH can be managed obviously through medication, but that's like technically treating like hypothyroidism and not necessarily like the antibodies of the actual autoimmune factor. But normally when your TSH is in check, like everything's kind of in check, but sometimes you can be in like a flare, or I don't know, I guess it's hard for me to wrap my mind around like if your body is not in the ideal state, like how can it accept a pregnancy, you know?
Right. Yeah. And that is challenging. You know, when your body is not, you know, when you're in a flare, your body is really stressed, and that similarly will sort of shut down communication between the brain and the ovary in a different mechanism through cortisol often. And then your body you won't ovulate because that brain ovary communication is shut down. So that can impact fertility. But then there's also all of this thought about like how these antibodies can potentially be impacting implantation. And I think we don't know a whole lot about it yet. And that's where the research will come in. And the way that I think about implantation, it's like a spaceship, like setting down on Mars or something. And, we know that the embryo, there's apposition, there's invasion into the endometrium, but then all the stuff that happens downstream from that, it's like a million different pathways that are intersecting with each other. And yes, we know that we know some of those pathways. We don't know all of those pathways, and how are those immunoglobulins, the antibodies, impacting that? Are they impacting that? I think AI will be really helpful in sort of connecting all of these pieces together, but it's still sort of in its infancy in what we know about how that impacts implantation.
Well, and that's why I think a lot of people if you haven't been through IVF, it's hard to wrap your head around the fact that it doesn't work 100% of the time. And there's always that, like, even in the most perfect cycle, perfect embryo transfer, it's like a 70% chance, right?
Of success, yeah. And then 65-70% chance with the first transfer. But then with the second transfer, 90%, third transfer, 95%. By the fifth, it's like 98%. And so I think with going down this rabbit hole of recurrent implantation failure, it's really, really rare. And I know that you've experienced that yourself. And,
my rainbow baby was lucky transfer number 6.
Yes. But I think that, you made whole, without knowing your whole history, you made brand new and new embryos too, right?
I did. Yep.
And I think that, I go to all these conferences and sit and listen to these expert panels about recurrent implantation failure. And the thought is that it's most likely an embryo issue and not a window of implantation issue. I mean, it could be issues with the crosstalk between the embryo and the environment in the uterus. But again, that's still in its infancy. We really don't know a whole lot about that.
Yep.
And so the main thought is that it's most likely the embryo where there's the problem. And I mean, again, who knows what's happening with embryos numbers, 1 through 5 in your first transfers. But when you made new ones, I mean, maybe there was something different about the environment that those embryos were created in, and they were just better embryos. We just don't know. So I agree with you that I'm excited to see what is discovered in the coming years, because this research moves really quickly usually.
So. I did not know that by the 5th transfer, it was a 98% success rate. That's really encouraging. That's awesome.
I have all these patients who, I do my Fertility Friday Q&As, and, I have all these patients that, put in their own personal information, and I don't really give personal answers at all. But, my thought is really they failed 2 transfers, and it's transfer another one, check the boxes, make sure that the uterus is fine, that, the cycle couldn't be improved at all, but transfer another embryo, because there's a good chance that it'll work.
Yeah, absolutely.
Women's Health in the Wild, must reads, must sees, and must tries for your wellness journey.
In Women's Health in the Wild, we're talking all about new research by companies like NextGen, Jane, and Qvin. I think that's how you pronounce it. They're exploring the use of menstrual blood to develop non-invasive diagnostic tools with the goal of detecting conditions such as endometriosis and hormonal imbalances earlier and more accurately. This could potentially transform reproductive health care by providing women with less invasive options for diagnosis. Sounds like a total game changer, but what's kind of the 411 here?
Got it. So a couple things. One, I have a little bit of an issue with the term hormone imbalances here, because hormones fluctuate during a menstrual cycle in very specific ways. There are times when hormones are supposed to be low, at the beginning of a menstrual cycle when you're bleeding, and times when hormones are supposed to be high, around the time of ovulation.
Yep.
And sure, you can have high hormone levels at the beginning of a cycle, which would be abnormal, but I wouldn't call that an imbalance. And that's actually a sign of a potential cyst or low ovarian reserve. And the treatment is not to balance the hormones, it's to fix the underlying problem or address, have a further investigation of what's going on.
Yeah.
The other thing is that using menstrual blood can only give you insight into hormone levels during menses. And it's like a really small window. So while it's true that hormone levels at the beginning of a cycle, usually between days 2 and 4 of the cycle, are a key component of a fertility and reproductive hormone workup, this doesn't like get you out of the rest of the testing that's required later on in the cycle when there's no menstrual blood to be had. And so I think that's an important
and also like
point.
menstrual blood is specific to that cycle too.
Exactly.
Yeah.
You could like have a cyst in one cycle and the hormone levels would be one way and like no cyst in another cycle, Overall, I think this technology is really interesting and maybe an easy way for people to have this early day 3 testing prior to seeing a fertility doctor, like not having to run to LabCorp or run to their doctor on their day 3 to like get their blood drawn. Like maybe that's a potential use for it. But these levels really need to be interpreted in the context of the patient's symptoms and medical history, which really takes a reproductive specialist to do so.
Yeah.
I've had patients like get these like blood work done and like, oh, it falls in that normal range that they give you with the blood work results and doesn't really tell you what's happening. So,
yeah. I wonder with endometriosis though, if it could be helpful in diagnosing.
Yeah, I think if they're using specific biomarkers, there's this test, we've talked about this before, Receptiva, but this is done like at a very specific time in the menstrual cycle when there is no menstrual blood. And so I think there's certainly future potential for this. And I think that's really exciting. This is just like the beginning stages of this. And, but we'll have to wait and see, if it's helpful in making other diagnoses down the line.
Yeah. I think that's like the message here is just in general, there's so much amazing research being done and around women's health. And hopefully, I've said this before on the podcast, but like in 10 years, I'm really hopeful that, women won't deal with like long times to diagnosis and having to figure out for years, like what's going on with their bodies. And so it's a really hopeful time.
Yeah. I think about our first recording session with Tara Lipinski's story about how she talks about how long it took her to get an infertility diagnosis. And I talk about this all the time with patients who come with like unexplained infertility and pain and how hard it is to make this diagnosis because who wants to have like just exploratory surgery?
Yeah.
So, but it's so true. I think that there's a lot of room for improvement in the diagnosis. And so if this is the first start, then, I'm here for it. I'm excited to see, what comes of it.
Yes. And on that note, I know you have an embryo transfer to get to, so I'll let you go because I know the timing of that is very important.
Thank you. It was so great to see you.
I'll see you next time.
Thanks for tuning in to From First Period to Last Period. If you enjoyed today's episode, be sure to hit subscribe so you don't miss any of our future conversations.
And don't forget to share this with your friends, because when it comes to women's health, we all deserve to be informed, empowered, and supported.
Still have questions? Email community@rescripted.com for a chance to have yours answered on a future episode. For more science-backed women's health content that meets you exactly where you are, head to rescripted.com or follow us on social @HelloRescripted.
We'll see you next time with more real stories and expert advice.